Thank you.
Hope I am audible. Yeah. Thank you, Dr. Fauzi, for the invitation to present our pioneering work in our part of the India. And thank you for the wonderful hospitality. And let me go into the MR guided focused ultrasound for treating neuro work. And greetings from my chairman, Dr. K. Madheshwaran, who is a practicing neurosurgeon, and he was instrumental in bringing the MR guided focused ultrasound for treating Parkinson's and essential tremors for the very first time in India. And this is our team. It's a team of radiologists, neurosurgeons, and the neurologists. We work as a team. And MR guided focused ultrasound is a treatment option for patients with essential tremors or Parkinson's disease who haven't responded to medication or are not willing to have an invasive surgery. The procedure uses focused beams of ultrasonic energy guided by MRI to target areas deep in the brain. No incisions, no implants, no radiation. As the evolution happened, like in the early 1990s, the phased array elements were developed, and real-time MR thermometry also developed in the mid-1990s. In 2001, the Insightec developed the first MR-guided focused ultrasound system. And after the randomized controlled trials of MR thalatomy for essential tremors and Parkinson's disease, the FDA approved in the year 2016 for treating essential tremors in US and Canada, and in 2018 it also approved for treating patients with tremor-dominant Parkinson's disease. With its extension in 2021, the FDA approved for treating advanced Parkinson's disease, patients suffering with mobility, rigidity, dyskinesia. So it's a single session, incision-less transcranial ablation in the region of interest, delivering ultrasound waves across select points under real-time MR thermal monitoring. The targets include ventralis intermedius and ventralis oralis for tremors and pallidothalamic tract for bradykinesia, rigidity, and dystonias. So we generally treat multiple nuclei, Vim vivo, PTT, subthalamic nucleus, and GPA. For Parkinson's disease and for essential tremors, we target ventralis intermedius and posterior subthalamic area. We use a 3T MRI scanner with the Insightec Exablate Neuro system. The patient will be awake during the entire procedure. Initial temporary sonications with a mean temperature of 48 to 50 degrees are done as test sonication to evaluate on-table clinical outcome, followed by sonications with mean temperature of more than 52 to 55 degrees, which produces a permanent lesion. This is the MR system with the mobile unit and the helmet-shaped transducer. And the helmet-shaped transducer has 1024 phased array elements, and it operates at a frequency of 650 kilohertz. And with its advanced focusing algorithms, we make a precise focal spot of 2 to 3 mm. The ultrasound pulses range from 50 to 60 seconds duration to deliver the area by multiple sonications. This is the external cooling system which stores the water. It's a degassed water. And treatment options for movement disorders include medical management and surgical management. As you can see, there are ablative procedures like stereotactic surgery, which is not generally used. RF thermal ablations are used. MR-guided focused ultrasound has an edge over the deep brain stimulation. This is how the patient is prepared. You can see the stereotactic arm, which is fixed to the patient's head by using 2 screws in the anterior frontal portion and in the 2 at the posterior portion, and a membrane is placed over the head. And you can see the circulating cooled degassed water in between the patient's head and the transducer. This is how the patient is positioned on the couch. One important factor is skull density ratio, which quantifies the acoustic transparency of skull by analyzing the ratio of cortical to the trabecular bone density. It's a very important barrier for ultrasound traversing into the brain. The 3 main important factors are the skull density ratio, skull volume, and the incidence angle of the acoustic rays against the skull surface. As you can see, skull distorts the ultrasound waves. Some absorbs energy leading to skull heating and attenuates the ultrasound beam. We take with the parameters a high spatial resolution volumetric data of 0.625 mm thickness is obtained and fed into the exabyte neuro system, and we have to calculate using these parameters. And the SDR ranges from 0.4 to 0.7. So SDR more than 0.5, it has an excellent ultrasound penetration, and with SDRs lower than 0.30 has a poor penetration, and it includes high risk of skull heating. So higher the SDR, less joule energy is required to make a lesion, and with low SDR, high joule energy is required to make a lesion. So general, the requirement is minimum out of 1024 elements, 750 elements should be on, and the skull surface area should be above 250 centimeters square. Although low SDR with less than 0.3 and skull volume of more than 330 are not contraindications to MRGFUS, but higher energy, sonication power, duration, and the number of sonications may be required to achieve a therapeutic temperature above 52 degrees to make a permanent thermal lesion. This is our study on the Indian population of the SDR values. The Indian population has a mean value of 0.56, which is excellent. And when you compare with the Korean or the Japanese or Chinese, 30% of their population has SDR values of less than 0.3. So coming to the nucleus, ventral intermediate nucleus of the thalamus is a very important area that plays a vital role in the tremor mechanism in Parkinson's disease. So we target that area. Determining the VIM location using image modalities is very difficult. Even a 3T MR will not distinguish the nucleus of the thalamus. So the standard target for VIM as given as the 25% of the length between the anterior and posterior commissure in front of the PZ, and 14 mm lateral from the midline, and it is located at the intercommissural plane, that is the ACPC plane. And the another method is calculating via the VIM line. So we have pre-procedural planning time to define the targets, and this is how we calculate the targets using US targets, Professor Tyra's method, and VIM line target, and even we have developed our own RCH target marking system. The treatment process includes the patient preparation, planning, target verification, treatment, and assessment. As you can see, there are 4 phases of sonication. The first one is the align phase to check the shape, temperature, and location, and the verify phase, we do the clinical assessment intraprocedurally, and at the treat low, we target the lesions, and that creates the permanent lesioning. We generally don't go to treat high, which requires 55 degrees to 60 degrees. And this is how the shape of the lesion comes during the verify phase, and during the treat low phase, you can see the red area, which is the targeted area, and it is well within the thing. And all the safer zones like the internal capsule are marked prior so that it's not deviated. So this is the VIM vivo lesioning. As you can see, it's nearby to the internal capsule, but we make a very good lesioning. And this is an example for the PTT, palatothalamic tract and STN lesioning. And this is how the posterior subthalamic area is marked and targeted. Coming to the intra and post procedure imaging, T2 weighted imaging is the most useful sequence for visualizing the ablation outcome. Sonications produce heat at the region of interest that causes necrosis of the center, which is followed by concentric rims of vasogenic and cytotoxic edema. All 3 zones will not be present at all times. So you can see the inner zone is the necrotic area, and the cytotoxic and vasogenic edema gradually decreases, and this is an post procedure images. And this is the first procedure. We did it on August 2022 when we started the MRGFS program for the very first time in India. And he was a patient of tremor-dominant Parkinson's disease, and for the 10 years he was dependent on his family support for his day-to-day activities. And immediately after the post-procedure, he started writing on his own, as you can see in the procedural notes. And this is how the evolution happens during the procedure itself, just pre-procedure, intra-procedure, and just the post-procedure status. And this is how we evaluate the intra-op evaluation. And you can see some examples of these things. And coming to a case, and 46-year-old male, rheumatoid and Parkinson's disease for more than 8 years. He was an entrepreneur from Dubai with marked hypokinesia and severe drug-induced dyskinesia, and his skull density ratio was 0.43. And he had a severe drug-induced dyskinesias. And you can see his tremors and even the tremors in his jaw. You can see the initiation is very, very slow, and then it is very difficult for him to move around. And this is the post-procedure of first thing. And this is immediately after the procedure. That night he started taking his own food with his own hands after a gap of 8 years. And the same morning he was jogging along the corridors without any hesitation and starting initiations. And this is one more patient, Parkinson's patient with severe cervical dystonias, and she was also cured of dystonia. And this is one of our patient who started painting after a gap of 10 years, and he presented to us after the procedure. The future, right now we have been using it for movement disorders, for obsessive compulsive disorder, depression, and chronic neuropathic pain. The future lies on the blood-brain barrier breakage, where all the typical clinical trials are going on in Japan and other parts of the world for treating tumors, for neurological disease, and for epilepsy, and for other tumors. There's a lot of things going on apart from neuro. There are multiple things going on in the world. In conclusion, so far we have completed around 210 treatments at trial care. 20% were essential tremors and 80% were Parkinson's disease cases, which includes dystonic and specific SCA12 patients who are in northern part of India. We have a complete follow-up of 3 to 39 months. So far, no major complications. There were minor complications like transient ataxia, dysarthria, weakness, somnolence, and headache, which gets resolved by 2 weeks to 2 months' time. So transforming movement disorder care, our experience so far with MRGFUS has been very precise, safe, and the patient acceptance is in 100%. It's very safe across all age groups. We have started treating the age group of age 28 to 93 years, and everyone are doing really, really well. And the future of MRGFS may play a vital role in treating many other conditions. As you can see, there are a lot of other presentations also coming up. And this is my team just before our first procedure, the selfie taken, and this is the second picture is after the completion of 200 procedures. So everyone are invited to India to witness this revolution, and thank you, Dr. Fauzi. And thank you.
Great work actually, and